Now, when a woman gets pelvic inflammatory disease for the first time, they stand at a risk of about 15% of developing infertility. And when they get about 3 recurrences of pelvic inflammatory disease, that risk even skyrockets to about 75%. So someone who has had PID about 3 times is more likely to have up to 75% chances of failing to conceive naturally. And that is just a tip of the iceberg and the different things that are involved, or the different complications of pelvic inflammatory disease that make it a worthwhile topic knowing and understanding fully, as well as making it time favorite on examinations. So this is what you have to understand. This is made one pager, and basically what we do here is we get a topic that is very important or high yield and summarize it on a single page, so you can study it with me. I can take you through the different clinical aspects of it, and then you can go ahead and download the summary at the website, that is www.madeonepager.com. And on that summary, there are some quiz questions that are attached, up to 20 quiz questions, and you can do all this for free. So let's get started. So pelvic inflammatory disease is going to be an ascending polymicrobial infection. Different organisms are going to be involved, and it's going to affect the upper female genital tract. So when you look at the female genital tract, you can divide it into the lower genital tract, that's the vagina and the cervix, and then the upper genital tract, that is the uterus and the fallopian tubes, and then the ovaries. So what happens is that we can get an endometritis, which is inflammation of the inner lining of the uterus. We can get a salpingitis, which is inflammation of the fallopian tubes, a tubal ovarian abscess, a pelvic peritonitis. Remember, the female reproductive system is the reproductive system which has a communication to the abdomen. So we have the abdominal ostium, and that is a hole through which we can have contacts leak between the abdomen and the uterus. And then we can get a perihepatitis that is called the Fitzhugh-Curtis syndrome, and we shall look at it in a short time. So why it matters is because untreated or delayed PID can cause tubal scarring. This is scarring of the fallopian tubes, and this is going to lead to infertility, because once they are scarred, the fallopian tubes are supposed to have cilia that propels the ovum, and also they have to be open so that things can pass through. So if there is scarring, they kink, they go ahead and narrow, and that could prevent the movement of the ovum very well, and that could either cause infertility and most times increase the risk of developing an ectopic pregnancy. And we covered ectopic pregnancy in a video, so if you are not very conversant with the concept, you can check out the video in the OBGYN playlist. It's there. Then we have chronic pelvic pain, and it's very important, because if you do not treat PID very well, this woman is going to have chronic pelvic pain, and it will be very, very disabling or discomforting throughout their life. And then recurrency is a very, very important thing to know, because we have looked at it, and 75% of people who have a third recurrency go on to be infertile. So the risk factors is age less than 25, and this could be maybe associated with the sexual practices and things like that, and new or multiple partners, and previous STI or PID, partner with STI, it's a sexually transmitted infections, unprotected sex, recent uterine instrumentation. So we can have this infection of the upper genital tract occurring after instrumentation, things like evacuation of the uterus after they have had an abortion or miscarriage, during delivery, hysteroscopy, intrauterine devices can also be risk factors. So what happens is that pathophysiology is that we have the cervicitis or a vaginal infection. Now, when we talk about the cervicitis, this is very, very specific to the cervix, and this is where the organisms like gonorrhoea and chlamydia are going to affect the reproductive system. Because when you look at the vagina has a squamous epithelium, so it has a stratified squamous epithelium, so it is resistant to N gonorrhoea and N chlamydia. So those two are just going to cause a cervicitis. And the vaginal infection can come from then the other organisms. And in the previous video, we talked about bacterial vaginosis, which is where we have this dysbiosis. So you can check that out in the OBGYN playlists. The video is called abnormal vaginal discharge. So then we have an endometritis occurring after this cervicitis, and after the endometritis we have a salpingitis where the tubes become edematous. They have exudates, adhesions and scarring, and this is going to eventually cause infertility or ectopic pregnancy. So we can classify pelvic inflammatory disease by the duration. We can have the acute, that is less than 30 days, and the acute is going to be symptomatic pelvic pain or tenderness. This is mostly going to be caused by gonorrhoeae. So this is very, very fast. It's going to progress very fast, and most of the time the gonorrhoeae is going to actually lead to formation of an abscess. So when you look at the acute form of PID, it's going to be very, very painful and very fast. Then the subclinical is the silent one. Someone gets an STI, that's mostly chlamydia. It goes on to cause a PID, but in a subtle way. The person may not actually feel too much pain, and by the time they realize they have it, it's when they have already tubal damage. And most of the time, these people are going to firstly present with infertility. They come in with the complaints that they cannot, they are trying to have kids and they are not, and only to see that the tubes have already been damaged by the chlamydia. Then we have the chronic or recurrent, and this one is recurrent or persistent inflammation, or the sequel that follows pelvic inflammatory disease. And you have to think about adhesions that would have been caused by the infections. Chronic pelvic pain. We have sometimes TB. TB can spread hematogenously also to the reproductive system, and actinomyces in selected cases. So PID can also be classified by the cause. We have the PID that is caused by sexually transmitted infections. That's chlamydia, trachomatis, gonorrhoeae, and mycobacterium genitalium, the most common STIs. Then it can be polymicrobial or bacterial vaginosis flora. That could be the cause of the PID, and this is a bit rare, but anaerobes as well as gonorrhoeae and the vaginal flora can go ahead and cause a pelvic inflammatory disease. That includes even candida. So candidiasis or fungus can also cause a pelvic inflammatory disease. Then we have the post-procedural. That's going to be abortion, miscarriage, delivery, dilation and curettage, hysteroscopy, and then IUD insertion. All these can carry the organisms with them into the uterus and then cause an infection upwards. Then chronic PID is specific, and sometimes it's caused by genital TB as well as actinomyces. Then in virgins, you have to always make sure to rule out TB if they have a pelvic inflammatory disease. So when we look at the clinical features or the signs and symptoms, we have the symptoms of lower abdominal pain, and this is almost always going to be there. Abnormal discharge is going to happen. We have the deep dyspareunia. We have intermenstrual or postcoital bleeding, dysuria, fever and chills, nausea and vomiting, and these may be mild or even they can be asymptomatic in some cases, like we have seen in chlamydia, that they may not manifest with symptoms earlier on. And the signs they have is that they will have low abdominal tenderness, but then these big three are very, very important. The cervical motion tenderness, that is when you're doing the vaginal examination and you try to do some movement on the cervix. They have cervical motion tenderness, they have uterine tenderness as well as adnexal tenderness. And then we can have mucopurulent cervicitis. This is mostly for those organisms that cause the cervicitis, that is gonorrhoea and chlamydia. And then they can have fever, adnexal mass, and whenever they have an adnexal mass, you may suspect that they have a tubal ovarian abscess. So when you try to palpate around the adnexal region, you'll feel that there is a mass there. So the diagnosis is clinical, and we have the minimum criteria as well as the additional criteria, and then the definitive criteria. So the minimum criteria, this is from the CDC. And if someone has one of the following, you want to start them immediately on antibiotics or on treatment for this pelvic inflammatory disease. And this is because you better over-treat this than under-treat it. So cervical motion tenderness, uterine tenderness, and adnexal tenderness. One of these, you want to already begin them on treatment. You don't have to wait for labs or anything like that. And as we have seen here, it's a clinical diagnosis. So if you find this, you treat immediately. The additional criteria, these support the diagnosis but are not required. They may have a fever that is greater than 38.3 degrees Celsius. They may have abnormal mucopurulent cervical or vaginal discharge, cervical friability, many WC, that's white blood cells from saline microscopy or wet mount. They may have a raised ESR, a raised CRP, or the laboratory evidence of gonorrhoeae or trachomatis infection. This can be the NAAT test, or even the fast void urine. can be sometimes used to increase suspicion if you can't do the NAAT test. So we have the more specific or the confirmatory criteria, and this one is useful in the diagnosis is uncertain or if there's severe disease. And one of the things we can do is an endometrial biopsy that will show endometritis. So that is inflammation of the inner pelvic lining. So that is endometritis. Then you can do a transvaginal ultrasound, and on the ultrasound you may see thickened fluid-filled tubes. So once the tubes show thickening or they are fluid-filled, the free fluid in the pelvic region, and also a tubal ovarian complex, you want to suspect that probably these people are having an infectious something going on. Then on laparoscopy, and this is the gold standard, you may find that they are showing a PID or salpingitis. This is using laparoscopic cameras. You go in and you see a hyperemic tube, a tube that is reddened. This is a feature of inflammation. Pysulfings, which is going to be pus in the tubes. Then a tubal ovarian mass. These are all going to be definitive or for more specific when it comes to confirming presence of PID. Then investigations, you can do the pregnancy test, you can do the NAAT test for chlamydia and gonorrhoea, you can do the HIV and syphilis testing, a full blood count and CRP or ESR, you can do urinalysis and culture, a wet mount, you can do transvaginal ultrasonography. Differentials for this include ectopic pregnancy, appendicitis, ovarian torsion, ruptured ovarian, endometriosis, UTI and perionephritis, renal colic, septic portion, and gastroenteritis. And basically, these are all causes of an acute abdomen down there, or basically other gynecological issues going on. So it's important that you keep them in mind. So when you look at the treatment, we have the outpatient treatment, and this is the most common when you have no complications, the patient is stable, and the condition is subtle. So you can use subtraction, that's 500 milligrams IM, and it's going to be a start or a single dose. You give them this single dose injection, and then they go home with doxycycline. And it's important to know that it's an intramuscular injection, not IV. Then they go and take doxycycline 100 milligrams per oral, that is BD for 14 days, metronidazole 500 BD for 14 days. And it's important that you always give this for 14 days, because once you don't give for 14 days and you give for less than 14 days, these people are going to come back with a recurrence. And we say whenever they have a recurrence, the chances of infertility go even higher and higher, or even other complications. Then if they are greater than 150 kilograms, then you can consider giving ceftriaxone 1 gram IM. So you want to admit them then if they are pregnant, if there's severe illness, high fever, vomiting, if they have a suspected ovarian abscess, you don't want to keep them at home. If they have a peritonitis and sepsis, a surgical emergency not excluded, you're not sure, are they having appendicitis, are they having something else going on, then keep them. They're unable to tolerate oral treatment, poor adherence, especially sometimes people don't tolerate doxycycline, or if there is poor follow-up, if there is no improvement after 48 to 72 hours on outpatient therapy, then you want to tell them to return for admission. So inpatient, what you're going to do, you're going to give IV ceftriaxone, that's 1 gram OD, and then doxycycline. And doxycycline can be given orally or IV, but the IV kind of causes irritation, and the availability of doxy, both IV and oral, is almost the same. Then you can give them metronidazole 500, that can be also IV or per oral, depending on your preference. Then after, if there is improvement, when they improve, then you switch them to oral, and then complete the 14 days of total treatment. Make sure that you always have 14 days of treatment. So we have alternative regimens, and these ones may vary a bit depending on the guidelines in the area, but you should know them that there are other alternative regimens. Some of the things that are done is that we can use cefoxitin or ceftoten, we can use ampicillin, sulbactam, and doxycycline, as well as they can use clindamycin and gentamicin. But the rule is you want to cover for chlamydia, gonorrhoea, as well as anaerobes at all times. So if they have an IUD, most of the time it's not routinely removed if it's not severe. But yeah, if you give the management 48 hours and there's no improvement, then you can consider removing that IUD. Or if your patient asks you to remove it, then you can go ahead and remove the IUD. So the complications, infertility is how it comes about: ectopic pregnancy, chronic pelvic pain, recurrent PID, tubal ovarian abscess, pelvic adhesions, the Fitzhugh-Curtis syndrome, and this one is very important. And it's a triad of pelvic inflammatory disease with right upper quadrant pain and perihepatitis. And then we can have sepsis and peritonitis if the tubal ovarian abscess goes ahead to rupture. So partner management is that you want to treat and test partners from the last 60 days, and you want to cover for chlamydia and gonorrhoea. You want to avoid sex until the patient and partner recover completely and the symptoms resolve. So the follow-up, you want to review in 48-72 hours. If they're not improving, you want to admit, reassess, and then consider alternative diagnosis. And then we test for chlamydia and gonorrhea at 3 months. So the high yield things that you have to remember is that PID is a clinical diagnosis, and negative STI test does not rule it out. Always exclude an ectopic pregnancy. Treat early and don't wait for swads. When you have right back quadrant pain and PID, think about Fitzhugh-Curtis syndrome. Pregnancy, tubal ovarian abscess, and severe disease is equal to an admission, and if there's no improvement within 72 hours, reassess urgently. So we have come to the end of this video, and I hope you enjoyed it or learned a lot about pelvic inflammatory disease. Go ahead and visit the website www.med1pager.com, download this summary and try your questions. See you in the next video.